Hi there, podcast and public radio fans. Heath Drusen here, host and creator of the Extremely American podcast. I'm working on season 3, which is an urgent story about neo-Nazi terrorists and how they helped build a modern white supremacist movement, even from prison. Some of their ideas have even made it to today's White House. It's both a gripping true crime story and a timely warning about threats to our democracy. And this time, my investigative reporting is funded by you. To support the project, please make a tax-deductible contribution at extremelyamerican.org. That's extremelyamerican.org. And thanks.
From the studios of Boise State Public Radio News, I'm Gemma Gaudette. This is Idaho Matters. A COVID vaccine study that was expected to be published by the CDC earlier this year ended up being pulled after questions were raised about its research methods. Well, now that study has been published in a major medical journal, and its findings suggest the latest COVID vaccine cut the risk of hospitalization by more than half. The controversy has raised questions not only about vaccine effectiveness, but also about the role of science and politics, as well as public health agencies. It is Wednesday, which means Dr. David Pate is joining us. He is the former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak. Hi, Dr. Pate. Hi,
Gemma.
And folks, if you have a public health question, send us an email, idahomatters@boisestate.edu, and we will be getting to some listener questions later in the program. So, Dr. Pate, I want to start with the study itself, if we can. What stands out to you about these findings?
Well, I think the takeaway message, and this is not the only study to show it, but it's more evidence, and that is that getting the booster, the new COVID vaccine that comes out each fall, is giving additional protection, particularly from illness that would be significant enough to cause you to go to the urgent care, go to an emergency room, or be hospitalized. In fact, as you said, what this study showed is the most recent booster, that is the one that came out last August or September, which would be the 25-26 vaccine, that reduced your chances of ending up in the emergency room or urgent care by 50%, and it decreased the risk that you would be hospitalized for COVID by 55%. So what does that tell me? That tells me that, number one, whatever protection we have, and there is some from prior infection or vaccination, there is still benefit by staying current because this virus is changing so much. And so whatever protection we get from prior variants, from being infected with them or prior vaccines, that does wane, and there is benefit to getting the booster.
So I want to talk about the dispute itself, Dr. Pate, and why the FDA decided to pull the study. I'm sorry, I think it was the CDC, not the FDA, because it centered on something called a test negative study design. So I don't know what this is. I think the average person does it. Can you explain what it is and why researchers use this? And is this a widely accepted approach in vaccine research?
So let me start with your last question first. Yes, it's widely accepted. It's very common practice. We have done it for decades. And to be clear, the folks in the CDC that wanted to approve this study for publication, all the technical folks, they saw no problem with it because it's what we've always done. This was the interim director of the CDC, who happens to be the director for NIH, who has long had unconventional thoughts about COVID vaccines, who stopped it. The career folks wanted this to go ahead. So what is the study, as you asked? So a test negative means that what we do is we review cases in retrospect of people who
Mhm.
showed up to urgent care, emergency room, hospital, whatever it was. In this study, it was all three. And then you look at those that when they came in for complaint of whatever the illness is you're looking at. In this case, it was COVID, and those that tested positive. Then what they did is once they determined, okay, there was 1,000 people that had COVID, let's say, then they go back and look, did they receive that last updated vaccine? And if they, and then they compare the two groups, those that did receive that vaccine, those that didn't. And what they come out with is an odds ratio, basically, that in this case, what it showed is that as they looked at all of these patients who had come into urgent care, emergency room, and were hospitalized, that among the groups that tested negative when they came in for the same kind of symptoms, but didn't test positive for COVID, they were people that were previously vaccinated. And so now we come up with an odds that those that tested positive were twice as likely to not be vaccinated. And so this is something that we've done all the time. The advantage to
Mhm.
this is it can be easily done. It can be less expensively done. And what the director wanted was a different approach that is much more time consuming, much more expensive, and is not historically done. And that is to look prospectively, take people that are vaccinated and not vaccinated, and then see what happens to them. That's just much more, it can be done, but it takes a lot longer, it takes a lot more resources, more costly to do, and takes longer to do.
So, Dr. Pate, from your professional standing, what do you make of the decision to stop publication of that study after it had already gone through the scientific review process?
I think that was just pure political ideology. Dr. Bhattacharya's objection, um, that's fine. I mean, he can have that point of view, and that can be discussed and with experts, which he is not, and go over the pros and cons. There's pros and cons to every single approach that we take in scientific studies. But to stop a publication that would offer meaningful information for doctors across the country just because it involved a COVID vaccine, because he's not suggesting for the vaccines that treat other diseases that those need to be subjected to the same standard. So when people are not internally consistent, you know that either they don't understand or they're not sincere. And in this case, the technical staff had signed off on it. It was just like what we'd always done. But he and his boss, RFK Jr., don't know that their political constituents don't like the COVID vaccines. And so he had to come up with an excuse to stop it, and he did. But fortunately, that just means we'll use other methods and other journals to publish it. And this came out in a very good one.
So, Dr. Pate, for people trying to decide whether to get an updated COVID vaccine, and do we know if, I guess, they're going to be available or not? What should they take away from this research?
So I think it will be a recurring theme during our conversation today that there are people who are spreading disinformation, who are projecting views about vaccines based on political and ideological beliefs rather than scientific. So be very careful of that. What you should take away from this study is that the COVID vaccines remain effective. Sometimes people ask me, do I still need to get vaccinated? And the answer is that if you have underlying medical conditions, if you are um, older, 40s, 50s, certainly if you're past 60, and if you're concerned about post COVID complications, and we've talked about many of them before, and risk for cardiovascular disease in the year after COVID and so forth, then get that booster when it comes out. And it's safe and it is going to offer you protection.
I want to talk next now about a new flu vaccine that uses the same mRNA technology that's found in a lot of COVID shots. And it's cleared an important hurdle at the FDA, and it could change how quickly vaccines are updated to match circulating flu strains. So, Dr. Pate, let's just start with the basics. What makes this mRNA flu vaccine different from like the flu shots that we usually get every year?
So we have a number of different types of flu vaccines, but the vast majority of the flu vaccines in this country are produced on chicken eggs. We inject those eggs with the virus, and then it's a very lengthy process. It consumes a lot of chicken eggs, which could be a very big issue if there was an avian influenza outbreak. We might not have access to so many eggs, but it's lengthy. It takes about 6 months, and what you may recall from last year when we were talking about flu vaccines is that we certainly had evidence that there was a severe strain that we had seen in Australia. We were seeing it in some European countries. It had not yet hit the United States, but what we saw was that that virus had gone through about 7 mutations in the time from when our government decided on, okay, we'll use this strain as the basis for the vaccine to the time that it was going to hit our country. And unfortunately, you can't, there's no time to change the vaccine. And so the vaccine was not going to be as protective given all those changes to the virus. Now, with the mRNA technology, we can make those vaccines in half the time as chicken eggs, and including preparing it and distributing the vaccine. So this gives us a lot more flexibility. If we had decided that we wanted to change the flu vaccine type based on what we were seeing happen in the Southern Hemisphere, we would have had time to do that, and we could have changed and come out with a new version. And I mentioned avian influenza. We are certainly continuing to watch bird flu throughout the world. And if that were to ever take off in the human population, we may not have the chicken eggs we need, and we might not have the time to make conventional vaccines. So this could be a huge opportunity as we get better and better at making these mRNA vaccines, that we could have this in much greater numbers and much less time.
And Dr. Pate, the trial found the vaccine was about 27% more effective than a standard flu shot. Is that a significant improvement?
Very much. So, flu vaccines have been a challenge through time because, unlike, for example, the measles vaccine, which gives us very high levels of protection. We've never been able to get anywhere near those level of protections with the flu vaccine. Now, that the flu vaccine is still not beneficial and worth getting. I get it every year. And however, anything that we could do to make influenza vaccine even more effective is going to be a win. 27% improvement is very significant. So yes, that I'd love even more, but that is a very significant improvement.
And before we go to break, Dr. Pate, the advisory panel did recommend this unanimously. However, there are still questions about final approval. So, do we know what happens next in this process?
Well, this process has been an ugly one because, first of all, when they came for approval to the FDA with this mRNA vaccine months ago, um, again, the political leaders tried to change the rules on them and say, no, they wanted a study done a different way. And that was after the technical staff had already agreed that if Moderna did the study the way they had explained they were going to, that would be acceptable. So that caused us a big delay. Now, the problem is, and you see it was political because look what happened to the committee of experts. The committee of experts 100% endorsed this, whereas the political leader was trying to stop this vaccine. Now, the problem is if the FDA director does sign off on this, and the previous FDA director just resigned, so we only have an interim in place, and that is not a vaccine expert. I hope he will sign off on it. So that will be the first step. But then the second step is that this needs to go to the CDC's ACIP, or Advisory Committee on Illnesses, so that it can be approved in terms of the instructions of who can get it, when, and payers cover it. And unfortunately, because RFK Jr. appointed a committee of quacks to that, it got challenged in court. The judge said that the committee was unlawfully constituted. So it is now under a court order that it can't take any actions until an appropriate committee is put together. And there doesn't seem to be a lot of interest on RFK Jr.'s part in doing that. And I'm sure he's not going to be motivated to move quickly so that they can approve an mRNA vaccine because, of course, people are concerned, have already considered that mRNA is somehow bad. So this may not end up, it may get approved by the FDA, but it may not be available to people.
There's a growing flu outbreak at an Air Force basic training base in Texas, and it's been raising questions about military readiness as well as vaccine policies and whether the end of a longstanding flu vaccine mandate may have actually played a role in this outbreak. So, Dr. Page, first, what stands out to you about this outbreak and the fact that the number of cases appears to be growing pretty quickly?
What stands out to me is that this was expected by everybody except the Trump administration. Made a decision that went against everything that we've learned throughout history, because this has been tried and failed before, and it was a decision against what all of the public health and medical experts were saying. Don't do this because this is what's going to happen. Here and behold, it happened. And that is that if you have a lot of young people who in boot camp or training, they are physically exhausted, they are being stressed, they are all housed in very close quarters with each other, and then you have a respiratory virus and they're not vaccinated for it, they're going to spread. And it's going to spread just like it is right now with the high number of cases. And do you know when we learned about this? We learned about it more than 100 years ago, because
Mm.
this is how the 1918, 1919 Spanish flu pandemic started, which was not Spanish. It actually started in a military in the United States. So totally unsurprising. It's horribly sad that these to be the ones to prove that science was right, because now we've got 4 people hospitalized and possibly one death. They're still investigating to try to figure out why this one serviceman is horrible.
So we should note the military had required flu vaccinations for decades before Pete Hegseth made this optional earlier this year. But now, Dr. Pate, just in the last, I believe, day, we've now learned that some military branches are actually reinstating flu vaccine requirements for recruits and for certain high-risk groups. So does that suggest that officials actually see vaccination as an important tool, for keeping our troops healthy, but also for controlling an outbreak?
Well, yeah, I think it's just been proved, and again, for I don't know how many times now we've proved it. They tried to stop this policy back in the 40s, so over 50 years ago, and same thing happened. And I don't know why we have to keep repeating history, but yes, at least they've learned the lesson for right now. And let's hope that we can put an end to this nonsense, because this is already proved. We know what works and basically, if you stop vaccinating people for influenza, you'll get influenza outbreaks. What a shocker! And if you stop vaccinating people for measles, you'll get measles outbreaks. What a shocker! So it's time for us to get some sanity back to our public health policy, our military, our government. We need to stop making these kind of crazy decisions for ideology.
And Dr. Pate, you did mention that one recruit's death is under investigation right now, trying to figure out if it is flu related or not. In your professional opinion, I mean, how concerned should military leaders be right now when you see influenza leading to hospitalizations, when we're talking about otherwise young and very healthy recruits? I mean, these are young people. They are recruits into the military, and they have to go through physical testing, right, before they're even accepted into the military. So we know that outside of this, they are healthy.
Well, that's right. And there is commonly a thought that a lot of these respiratory viruses only kill old people. And that is simply not true. There is no question that the very young and the very old have a greater likelihood of bad outcomes. But we have all doctors, we've seen people in their 20s, 30s, 40s die from respiratory infections under some circumstances. And this is very concerning because it's not over. One of the things that we have to fear in people after they have influenza, and remember, you just said it again, these are military recruits that once they recover, they're going to get back to strenuous training. Well, we do see sometimes for a short period of time after influenza, we can see greater risk of certain cardiac events. We also have to be on the lookout for a complication after the virus clears, where now a bacteria goes into the lungs, and frankly, that often is a greater killer of people than the influenza virus itself. And so it's just as a doctor, who sees this as totally needless to put our young service people, our volunteers, our people that are true patriots to this country, have to put them through this because people at the top are not willing to seek competent advice and follow it. It's such a shame. And it's not over. We'll see what happens, but this is totally predictable.
So I want to switch now to the Ebola outbreak because Dr. Pate, France has confirmed its first case, and it's tied to this rapidly growing Ebola outbreak in the Democratic Republic of Congo. And health officials are working around the clock to contain what the United Nations says is the fastest growing Ebola outbreak in Africa's history. So French officials say the risk to the public is low, but how concerned should folks be when when an Ebola case is identified outside of that outbreak zone? And I believe this was a doctor who was working over in Africa.
Well, that's correct. France also already had two cases before this that were worrisome. Fortunately, they turned out to have different infections and not Ebola. Again, I went on my little tirade a little bit earlier that, we have to learn our lessons from history. And one is if you stop vaccinating for flu, you'll have flu outbreaks. If you stop vaccinating for measles, you'll have measles outbreaks. And another rule I'm just going to give to everybody free of charge. Hopefully not shocking to people. But if you stop supporting the public health infrastructure of the world, you will have outbreaks that don't get contained. When we cut off American funding, when we, now we're trying to do it on the back end, but we have cut off funding that could have supported infrastructure and help. And so, yes, this is the biggest Ebola outbreak they've had. With this particular strain of virus, this is only the third outbreak, and it's already the largest of that kind. And we're talking about over a quarter of these folks are dying that get infected. And the plain truth is that we are a very connected world. And the chances when you have an uncontained outbreak that and in countries that people may not think that a lot of people travel to or from the Congo or neighboring countries, but they do, and so it is a risk. Now, in the United States, the greatest risk is that it will be somebody that returns to the United States from there who because of the long incubation period, is fine when they start out, but they'll get very sick here in the United States, and then they will present to one of our emergency rooms. That is most likely how we're going to find out about it. And that's what happened the last time a patient showed up with Ebola. It was a U.S. citizen, and he returned from Africa, and he showed up in a Dallas hospital and infected two nurses at the hospital.
Yeah. So Dr. Pate, health officials, and we're talking, even World Health Organization officials are saying that misinformation as well as a lack of trust are hampering response efforts. And we're seeing that in our own country right now, right? With all of this lack of trust within the medical community. So how important is community trust? Not only when we're trying to contain a disease like Ebola, but frankly, as you said, right, we're trying to contain an influenza outbreak. The state of Utah has been dealing with a measles outbreak for a year now. Yeah. And yes, the cases are slowing down, but even Utah health officials are saying we're nowhere near the end of this.
Yeah, it's just it's so dismaying. If you were to look for a country that has all the recipes for this kind of uncontrolled outbreak, it would be the Democratic Republic of Congo. Why? Number one, they are at war. And when you have a war going on, first of all, that is a great facilitator of disease. And second, it makes it harder to respond to a disease outbreak. Number two, just as you said, lots of disinformation and people not trusting. They have had problems where people are attacking the hospitals because they're trying to retrieve their loved ones there, or even their loved one's body. And Ebola is one of those infections that can be transmitted from the body of somebody who's dead. What is happening is because of some of these attacks, we've even had Ebola patients who have fled the hospital. So they've left where they were in isolation and gone out trying to flee from the attacks on the hospital. And then we've had people that are the family members dealing with their dead loved ones, but because they don't have personal protective equipment or don't believe they need it, which even we've seen here in the United States with a much more educated population, that people just defy these kind of basic infection control processes, that they're spreading the infection in the funerals and funeral processes. So it's just it is really, really difficult circumstances. And then you add to that there are parts of the country that have very difficult access in terms of effective roads and all, difficult to get medical supplies into, may not have testing equipment or people to run the test. And it's a perfect recipe for this kind of a disaster, which is why we need to get on the front end of these things and fund these public health programs.
Dr. Pate, David wrote in and he said, my best friend is getting over another major cold flu event with symptoms of intense nausea, body aches, extreme fatigue, and coughing. He's had repeated bouts of these kinds of viruses since he caught COVID during the peak of the pandemic. So I want to know if he has long haul COVID, and could it make him more susceptible to these kinds of illnesses?
Well, David, it could be. We certainly have studies showing that people that have long COVID do seem to have an increased propensity for both bacterial and viral infections. And we have even seen this, it was reported last year, that just even in the case of a COVID infection, that even if mild, that people do seem to have an increased risk following that infection for bacterial and viral infections. So, yes, your hypothesis is plausible. Now, there are many other possible explanations as well. So I don't want to say that, yes, that's the cause. But if he's having a change and it seems like he's getting more and more infections, there are a number of other potentially serious reasons for that, and some that aren't so serious, but really should bring this to his doctor's attention and get evaluated.
So this is from Sue, and she said, I heard on Morning Edition about a new blood test called Gallery that can detect something like 50 different kinds of cancers. Is it true? And is it too good to be true? And if it is true, will it be too expensive for most of us?
Sue, those are excellent questions and just the right questions. So, is it true? It does appear that we are making progress, and this product is one example. In the past, we've typically been limited to looking to certain biomarkers, and one of the problems with that is a lot of times tumors don't make those enough that it gets into the blood until it's spread. What this test and some others that there are as well is doing look at for very subtle DNA changes to detect it so we can get it early. I think this won't be the end of the story. I think that actually there's some promising other techniques that might even be better. But to answer your question, yes, there is some evidence to suggest that this may be effective in picking up at least some cancers earlier. And the question about affordability is that
Hmm.
depends on whether this gets approved. If it doesn't get approved, they're probably going to run in the neighborhood of about $1,000. If it gets approved, then it might be covered by health insurance. But there's a lot of questions. What age should we start using this? How often should it be done? How often does this give us a false positive? In other words, that test comes back suggesting that you have cancer, but you don't really have it, or a false negative, that test comes back negative, but in fact, you do have that cancer. So we have a lot more work to do, but it's very promising.
And Dr. Pate, Mike sent us this email. He said, I heard that bird flu finally reached Australia. That means it's on every continent. So is this version different? And is it the really bad one that we keep hearing about? So what does this mean, not just for Australia, but for the rest of the world, if it's finally on every continent?
Well, and Mike, you're like Sue, you're asking all the exact right questions. So, first of all, this is the strain that we've been dealing with, the H5 virus, and it's the 2.3.4.4b strain, which is the one that we've had in our backyard flocks. We've had it in wild birds, and unfortunately into cattle. And if you're a long time listener, talking about that. So yes, this is a different strain. This is very concerning because of how rapidly this spreads and the vast number of species of birds and animals that this infects. Right now, this virus is not real efficient at infecting rather humans, but it can. And my greatest number one with our current state of disarray in public health at our highest levels here in the United States. We have decimated so much of the federal government that should be focused on this and studying it and coming up with plans to deal with it if it does become widespread in humans, which the really bad pandemics that we've had from flu started from avian strains. So this is a concern, and we're not really preparing. The other thing is, if you've heard me talk over, when you have a virus and you allow it to continue to spread at will, especially an RNA virus, which this is, it will mutate. And that's where we have to get worried that it's going to get better and better at adapting to. In fact, I hope that doesn't happen. But right now, we're not winning this war.
I have just under a minute left, and I want to get to one more question that Mike had, and it's about melatonin. He said he stopped using it because he read that it could have side effects of heart failure. He said he thought it didn't have any side effects. So what should people know about melatonin?
Well, melatonin is very popular. A lot of people have sleep difficulties. The problem is many sleep medications are habit forming or addictive. And so we always get excited when there are more other options that we don't have to be as concerned about with addiction and that kind of stuff. So melatonin is one of those. The body naturally makes it in your brain, and it naturally makes it in response to our normal cycle rhythm. And so when it starts getting darker, it starts increasing in production. So a lot of people take this for sleep. We cannot tell cause from this study, but it is concerning that what we saw was in people that had taken it more than a year, that they had a 3.5 times increase in the risk of hospitalization for heart failure. Now, this is one of those that, pardon the pun, I don't know what came first, the chicken or the egg, because we do know that some of these illnesses, like heart failure, cause sleep disturbances. So I'm not sure, but it's something that needs a lot more study, and we probably shouldn't take this for granted as a totally harmless medication to just stay on forever. My advice, if you're having problems sleeping that are requiring something to be taken on a regular basis, talk with your sleep study. Maybe you need a cardiac evaluation. There could be a number of things that need to be done.
Well, as always, Dr. Pate, we so appreciate you. We've been talking with Dr. David Pate, former CEO of St. Luke's Health System, as well as the co-author of the book, Preparing for the Next Global Outbreak. If you have questions for Dr. Pate, send us an email, idahomatters@boisestate.edu. Thanks so much for listening to this episode of Idaho Matters. And for quick news of the day, start your mornings with our podcast. It's called The Connector, Idaho Daily News. Find this and other Boise State Public Radio podcasts on Apple Podcasts, Spotify, or wherever you're listening right now.
Love Boise State Public Radio podcasts? They are free to enjoy, but not free to produce. If you can give, your support helps keep shows like Idaho Matters and Scandalize available to everyone. Donate now at boisestatepublicradio.org.